to talk about a topic that I have been interested in as of late, and I will be honest, I never really thought about this that much before. I mean, I thought about it, but I like kind of brought it up, but I never really like thought about it, or considered making it a thing until kind of recently. And maybe I should, but it's the use of the bougie, and not only the use of the bougie as an airway device, but the use of the bougie as your primary airway device when you're intubating. And that's probably something that almost no one in EMS does. Maybe a few services do, but by and large, I think most of us out there are not doing this in the field. Most of us are not doing this in the emergency department or any place else. We're just using the tube as our primary airway device outside of a laryngoscope. So I wanted to talk about that and the evidence behind potentially switching our practice and saying we should be using the bougie before we use any other device. Before we try to put a tube in, before you go in with the stylet and the tube, you should go in with a laryngoscope first, and then the bougie as the thing that goes into the actual trachea itself. But first, I have a little bit of a pitch for you. So, how many times have you showed up at a cardiac arrest and you go in and you think, oh, he's got basic Walt-like airway features, should be a mound potty one, something like that. No signs of difficult stuff, no facial hair or anything like that. This is going to be an easy airway. We're going to get this thing right in on the first time. And you put the scope in the patient's mouth, and you look in expecting to see this big thing, clear glottis, see all the structures, and we should be able to drive a Mack truck through there. Get it? It doesn't matter. Anyway, but you put the blade in, and what you actually find is this. Not that clear view, but just a bunch of pink stuff. And you look back, and there's not a grade 1, there's not a grade 2. You just see pink all over the place. Maybe a little bit of cords, maybe a little bit of cartilage, but certainly we don't think there's any way that we can possibly pass a tube down there. How many of us have gone in that situation and thought, well, here I am, boom, goose. And boom, try it again, goose. Would you like to avoid that frustration and the humiliation and the embarrassment and the terrible outcomes for your patient? Well, I have a device that I can use that will do so. And I've been working on it for a little while. It's cheap, it's cost effective, and it's simple to use with relatively small amount of training. And when you use this device, it increases the chance that you will get it into the trachea, get a tube into the trachea on the first time with any sort of difficult airway characteristics. So whether it's blood, whether it's cervical spine, immobilization, when studied with any difficult airway criteria predicted or seen, you increase the chance of first pass success, getting the tube in on the first time. Wow, that's pretty cool. Tell me more, Walt. All right, well, not only does it work in difficult airways, but it works to increase first pass success in all airways. Every patient looked at had an increased first pass success rate if you use my device first. That's amazing. We got to get this thing on the trucks, right? Not only that, it doesn't matter if the patient had cervical spine immobilization, or they had blood or vomit in their airway, or if they were obese. It's all improved first pass success with this awesome tool. And you ought to get out there and get this thing on your ambulance, because probably the coup de grace, if somebody's looking at metrics, is that it increases the chance of this at the bottom, definitive airway sans hypoxia on the first attempt. So if you get the thing in, you not only get it on your first attempt, but the chance that you get it without hypoxia or hypotension for that matter increases when you use my device, and increases significantly so. Wow, what an amazing product. Cool, huh? If I were to pitch this at a trade show, or I were to go to EMS World or something like that and set up a booth and say this is the data behind it, or get up on the stage and make a presentation on it, everybody would say, wow, this is really cool. Well, how do I get this on my truck? This would be the hot thing that everybody takes back to their service and says, we got to get this new thing. What is the thing? Well, it's this. It's the bougie. These things that I've cited to you here, with just a little bit of conflagration, are studies based on the use of the bougie as a first airway device. So this simple device that has been around since 1949 does all these things, or appears to do all these things in the best study that we have of it. So there's decent evidence that we should be using that. We'll talk about it a little bit more. First of all, why the bougie? Why should you think about using this thing at all? Now we think of this as a rescue device, and I'll tell you why I think that's a bad idea. But how about the problem itself? Well, the problem is that intubations in the field have to happen, and I think it is a necessary skill. However, we are not very successful pre-hospitally in general. You can see here on this upper graph, these are two different studies, by the way, but upper graph, paramedic success rate on an ambulance in your first attempt at intubating, under 50%, under coin flip whether or not you're going to get that right. A little bit better with HEMS nurse, and with a HEMS doctor, us really, supposed to be baller guys, still only 84% of the time are we getting it in on the first time. What does that mean? Well, partially it means that we work in a difficult environment and the airways are difficult in the field, and there's lots of stuff we can't control. But also, under 50% by paramedics kind of means probably we ought to look at that a little bit more and figure out if there's some way that we could at least get it up to that 85%. Because the 85% is still not great, but it's better than 46. So airways in the field are difficult. They're in a difficult situation, and honestly, most of the folks that perform it in the United States on an ambulance don't get very much training on it. I'm not saying that you're not maybe qualified, but under 50% success rate, maybe we should think about how we're doing this. Nonetheless, this is also borne out. If you think it's, oh, that's just one study, well, here's the part trial that was the iGel, this circle graph here, the iGel versus endotracheal intubation in cardiac arrest, and you found that they showed of their study subjects, 56% of the time was a successful on the first try. Again, pretty low. It's not 46, but it's just above a coin flip in that case. So our success rate in the field is not that high, and we probably need to do something about it. Now, I keep saying not first attempt success rate, but what about well, I can just get the tube in? Why doesn't that count? Why does it have to be on the first time? The problem is if you don't get it in on the first time, the chance of something bad happening to the patient goes up pretty significantly. So if you get the tube in on the first attempt, then you have about a 15% complication rate. Things like hypoxia, hypotension, significant bleeding, airway trauma, that kind of stuff. That starts off at about 15%. If you miss it the first time on your second attempt, there's almost a 50% chance that the patient is going to have one of these bad things happen to them. And we really don't want that to happen. And that continues to go up all the way through each attempt, up to 4+ attempts. It goes up to about 70%, meaning it's a much higher chance that something terrible or something bad is going to happen to the patient if it takes you 4 attempts. And we all kind of know that. But your first attempt should be the good one. Likewise, the chance that you are going to put it in the esophagus goes up significantly with each attempt at it. So we got to get this thing in the right place on the first shot each time to avoid bad stuff happening. Now, why doesn't that happen? Well, you take your typical airway. Why might we want to use a bougie for this one? What might be the benefit of this thing, which you've all seen, versus just putting a tube in? Well, you get a view like this, and you think, okay, well, that's pretty easy to hit. And of course, this is a laryngoscope view, so it's a little bit better. It's a little bit easier to see. It's a video, but you then have to think like, well, okay, I'm standing outside the patient, so I got to get it through his mouth. Still not impossible. We can still see okay. This still should be pretty easy to do. Okay, no problem. Until you realize that you have to put in some kind of laryngoscope. And all right, it's getting a little more difficult now. It's getting a little crowded in there, but let's go ahead and bring the tube in. We're ready to go. We still got a good view. Oh, the tube itself blocks your view of the cords in many cases. So you went from being able to see to the time when you actually have to pass the tube in, and now you can't see anything. What you can do with the bougie is avoid, it was written or designed for exactly this case. Instead of having this big giant tube that you can't see through, you can come in with a little piece of plastic, and now you have a view, you have room to manipulate. You can use the bougie as kind of your first, thread the needle through there, and then you can put the tube over top of that when you don't necessarily have to see all that well once the bougie is in place. So that's one indication for it. Other reasons, what if you put the tube in the mouth and you end up with this? You don't get that good view where it maybe is just a little bit obscured with like the tube. You just can't see anything to start with. Maybe you can see a little bit of the cords back there, like you can see the arytenoids just on the back side of this thing, but what is dominated is this big, friable, red, angry looking epiglottis. And you don't want to hit that thing. You don't want to whack that thing with a tube or try to grab it with a laryngoscope or anything like that. Maybe you want to finesse a bougie in underneath that thing and then get that in the trachea first. Likewise, with the bougie, you can get a little bit of confirmation, either as you run over the tracheal rings, you'll get these little clicks that you can feel through the bougie, or when you're passing the thing down, if you get to about 30 centimeters on the bougie, then the thing will usually stop because it gets stuck into the right bronchus and then meets some resistance. So you get that resistance, and you're like, okay, that's probably lungs. If you're in the esophagus, it just keeps on going all the way down into the stomach. So the hold up and the clicks are good little things to use when you can't see if you're actually in the trachea or not, although you suspect you are. And again, the indication for this initially for a grade 2B or 3 laryngoscopic view, where you can just see a little bit of the cords and you know that they're back there, but you can't visualize them entirely to put a tube in the place. This is the place where the bougie really was designed for, really shines. One last thing, say you put the tube in or you put the scope in and it looks something like this. You're under cardiac arrest. We got a little pulse check here, but it's complicated because all you see is frothy stuff coming up out of there. Maybe the patient's aspirated, maybe the patient's vomited, maybe the patient's just bleeding a lot. But then they go back under CPR. Now you can't see anything. Another good time for the bougie, because you have other ways of confirming that you're in the right spot, as well as being a little bit easier to manipulate and secure the airway even with blood or vomit in the airway itself. So why do we need the bougie? Because you can have any one of these 3 scenarios, and the bougie works really well for that. And you may say, well, why don't I just use it when I have one of these scenarios then? The problem is that you're not going to know about this stuff until you stick the scope into the patient's mouth. And if you are planning on using the tube first, the problem is, well, now I've got this tube in my hand and I feel like I want to just go for it because I got the tube there and I might be able to get it. And then we get into problems, because then you either can't see, or you start banging on the epiglottis or the arytenoids or the larynx otherwise. Or you try to ram it through there, through that vomit, and you don't have any good confirmation. You end up in the esophagus anyway. So you're not going to know that you have that difficult airway in a lot of cases until you actually get in there. So why not start with the thing in your hand that is what is the rescue device, quote unquote. And really, let's say it's not really a rescue device, because most of us don't practice enough with it to say like the rescue device. A rescue device should be something that you put in and you know is going to work. A lot of times we can fail with the bougie because we're not used to using it. You have to get the thing out. Even if we recognize that we need it, you have to say, hey, okay, give me the bougie. Well, somebody's got to unwrap the damn thing. And then oftentimes it's kind of bent up like that, and you have to straighten it out. And you have to figure out how you're doing it and hold the thing. And you're not really practiced with using it, so you end up in the wrong spot anyway. So get the thing out and make use of it so that you're not only facile with it when you do have to rescue yourself, but then you've got the better device in your hand ready to go, and you don't have to even think about, man, do I need the bougie on this one? You don't know. It doesn't matter if you have to, if you think you need the bougie or not. The bougie's in your hand. You're ready to go. We got it. Cool. So I wanted to do a quick case here, and I like cases if they're done well, and this one is done really well. And this is from Dr. Tarantrot, who put up a few cases over on his website, 5 Minute Airway, which is it's a phenomenal site. I wish he'd do some more of them, but I think he's just finishing up fellowship now in critical care, but really worth checking out some of this stuff where they comment on a lot of airway things. But check this out for a minute. I want him to present the case, and thank you, Tarantrot and Dr. Michael Elliott, for doing the commentary as they go through their case here.
All right, so then we're going into the intubation. We start right here with a decent view. Let's go ahead and start the video.
So we go to attempt intubation, and seemed rather straightforward at first.
Yeah, we're already seeing some difficulty getting some passage through the cord. I like how you're getting some twisting and trying to slide it past, but it looks like it's not working.
Yeah, that's when we had quite a bit of difficulty, and really were able to assess, and there was a lot more airway edema than we were expecting. There was also a large amount of mucus there. However, I felt that there was a clear view of the cords. I could see what I needed to see, so I elected not to remove the rather large phlegm there, if you will.
All right, so now it looks like we've tried passing with the tube. We're not getting it, and so now you've elected to go bougie. Now, did you consider just maybe going to a smaller size tube, or what made you go straight to the bougie here?
Well, I knew I had my bougie at hand, as I always do, right on top of the patient bedside. I felt that the airway was narrow enough with the size tube that we had, 7.5. I felt more comfortable attempting with a bougie. than to continue to increase airway edema with ramming it with an additional
Sure.
tube.
Sure. Now it looks like we're even having difficulty advancing the bougie with that coude tip.
Yeah, the coude tip really was working against us here. The angle on it really was not allowing us to catch a corner through the vocal cords to get it to pass. So ultimately we had to actually retract it out and flip around the bougie to the other side, which is a little bit against the grain, if you will.
Yeah, it's a little unconventional, definitely. It's, but when you realize what's going on, and that coude tip is what's preventing you from that angulation against the anterior portions, maybe that's what you really need. So then now we have the back of the bougie, right? Is that what we have?
Correct.
Here?
Now we're going back to the other side of the bougie, the back side.
So now this right here is a little difficult because it's actually hard for me to tell that we're actually past the vocal cords. Were you looking direct or were you looking video at this time?
So this is where there's some learning for myself as a resident. It would have been a prime opportunity to go ahead and suction out that mucus, as it was indeed obscuring my airway.
Yeah.
I had a pretty good feeling geospatially where the vocal cords were. However, I was not able to directly visualize them or through the video screen as the bougie was passing through the vocal cords.
Yeah, because that definitely looks a little dicey there. But you felt like it had gone through the cords there?
Yeah, I definitely felt like it had. I had a pretty good sense and feeling where the cords were in relation to the esophagus, and felt pretty comfortable as the bougie was sliding on down further. That is indeed in the trachea.
So here's one point of common criticism, is you could definitely leave the blade in once you got the bougie. Oh, maybe we lost the bougie. So what happened? So did you guys end up pulling? Oh no, I'm sorry. There it is right there. Okay, so you put the blade back in. Now we can see what's going on.
Yeah, so I put it back in there so you could get a better view. See as the tube would go
Perfect.
past it. Make
Perfect.
sure we were indeed intubating the correct structure.
Yeah, that's what I was going to recommend exactly. So this is getting on attempt number 3 here. How nervous were you getting at this point?
Yeah, by now you could definitely say this is a difficult airway. You mark that box wherever that box is at in the chart. We were definitely all sweating at this point. There was a lot of people in the room. Given the franticness of trying to get a patient who is morbidly obese out of a chair back into his bed, gain IV access, get him pre-oxygenated and ventilated prior to intubating, and then meeting all this was quite a hairy moment. But once we got that tube passed, there's definitely a sigh of relief.
Yeah, there we have it there. Nice. Well done.
So thanks again to Dr. Taryn Trout for letting me steal his video. Actually, he doesn't know that I stole it, but well, thanks, Taryn. Anyway, this, again, you didn't hear the beginning of that case, but basically it was a somewhat combative patient that had gotten himself kind of out of bed and it was in respiratory stress and they had to get him back in bed, but didn't have predictors other than like obesity that this was going to be a super challenging airway that they wouldn't have been able to get probably without the bougie, and it might have even gone on to necessitating like a cricothyrotomy or something like that. So good reason to have the bougie in your hand ready to go at the time when you're making your first attempt. So if you're going to do that, how do you do it? Most of us have sort of seen the bougie before, but many of us have not really been formally trained on it. I know when I take this out to some of our crews, everybody's like, well, yeah, I've seen that thing. Don't really know how it works or what you're supposed to do with it. And it does take a little bit of training. You know, there was some technique that Elliot had there that he had to use in order to get this thing in the right spot. Otherwise, you can really mess it up just like with anything else. So how do you do the thing? Real quick. Number one, and I won't go through this whole list. We'll do some other stuff here for a second. But you've got to prep the equipment first. So if you're going to use the bougie, get all the rest of your stuff out. Get your suction ready. Get your laryngoscope ready. Make sure that the light works. All that typical stuff that you would do. And go ahead and get your tube out. When you get the tube out, again, most of the time we're used to having the thing just with the stylet. If you're going to use the bougie, there's 2 ways you can kind of set it up. One is preloaded on the bougie itself. Now, I don't prefer this way just because of the way that I kind of go about it and what I like to have in my hand. But if you're going to load the thing first, the way people talk about it, you push the bougie down in there, you leave it sticking out, that far, and now you got this kind of heavy thing back here. Some folks will say, well, grab it something like that. I don't like that because that's kind of heavy and that's kind of in my way and I feel like I don't have good control of it. There's this thing called the Kiwi grip that people advocate, which is basically I'm taking the straight end of the bougie, the end up by the hub, and I'm going to run that through the Murphy eye of the bougie itself, and now I've got this now I've got this little like um, uh, thing that goes on the end of the ET tube, but I've still got the ET tube back here and I can still hold it and I can kind of turn it and rotate it and that kind of stuff. And I guess that's cool. I just never really have gotten into it. Per se. When you get the thing in, then you gotta do kind of a thing where you hold the tube in place, or you get the bougie in, and then you gotta pop that thing out, and then you still have to like slide the tube down, that kind of stuff. So not my favorite. I personally don't like the preloaded bougie. I like to just say, here's straight up, it's naked. It's ready to go. It is what it is, and it's nice and supple. I can be flexible with it. I don't have anything dangling on the end of it. The only problem with this is that once I get this into the patient's trachea, what I'm going to have to do is have somebody else or figure out some way to load this thing on the back and railroad it down over the top of that. Now, once you're in the trachea, you never want to let go of. You don't want to let go of the bougie itself or lose control of it. So you really need a helper to do that. So, but that's usually not that big a deal for me. We'll talk about that too in a minute. One more thing to kind of mention. At the last hospital that I worked at, the CPR Cardiac Resuscitation Committee, and I'm going to rag on them a little bit, they specifically said we don't want bougies on the crash carts because they bend and then they're ruined once they bend. They're only good if you get them straight out of the package. And any of us who have used these in the pre-hospital setting know that usually what happens is this gets stuffed into a an iron duck bag or something like that, and it gets bent. They get bent. They do this thing that looks something like that. You pull the thing out, and you're like, well, shit, this one's bad. Throw it away. That's not true. This is not broken. They are flexible. They're malleable and they have memory so that you can shape them in the way that you want. So there, even though that thing was bent pretty good, I can reshape it into whatever shape I want. I can put a little bend here. I could make the coude a little bit bigger or a little bit shallower. I could make it more arcuate right here or something like that. Bending the thing is not necessarily bad. It just takes a little bit of force in the opposite direction to straighten it back out, and then it's got memory and it's back to usable, straight, however you want. So just because it's bent doesn't mean that it's bad. You can usually straighten them back out. So we get the bougie out. We inspect it. We make sure we know what we're doing. We find the coude part. Either load the tube or don't load the tube, and you get it into whatever shape you think that you're gonna need. Now we can begin the actual attempt. So here we go. We've got our checklist on the side of us. We've done all the airway stuff. We've got apneic oxygenation on the patient. We've pre-oxygenated him real well. We have the bag. We have everything. We're ready to go. And we put the tube in the mouth. And you look in, and sure enough, you get like a grade 3 view, something like that. You can just see the back of the posterior part of the arytenoids, but not the cords themselves. Great time. Glad we had the bougie in our hand. So what he's going to do is go down. If the epiglottis is kind of sitting up here and here's the mouth, he's going to go down, up underneath the epiglottis, and into the trachea back there. You'll see that in just a second here as he kind of gets loaded and moving. Here he goes. Bougie will come in from the right-hand side. There's the back of the arytenoids there. You can just see him. He's going to come in. And he's going to use that tip to jump up underneath the epiglottis there, even without being able to see it. Now, once he gets in there, he still can't see that he's in the right spot, but he has some confirmation because he'll feel some clicking as the bougie runs along that laryngeal cartilage, the tracheal cartilage there. So he'll get some confirmation that he thinks is in the right spot. And again, he'll get that hold up that I sort of talked about before, where if you pass this bougie down at about 30 centimeters in an adult or so, the thing ought to get hold up. It ought to get some resistance. Now, you don't want to keep like shoving it down past that because that is the bougie going down in the right mainstem bronchus. And if it's not in the lungs, what it'll do is just keep on going straight down into the stomach. So that hold up is nice. That confirmation is nice. But you're going to do this standard laryngoscopy where we find the epiglottis, the arytenoids, and then find the cords. Pass the bougie through the cords. One of the other things that you're going to find here is that they keep the blade in the mouth once they start, and this is the same attempt, just repeated over for time's sake. So he is going to get the bougie in place. And here's this one other thing. Here he goes. Bougie again is going to come in from the right side. He's holding it more or less like a pencil sort of thing. That gives you a little bit of ability to flex the tip of it up and down. But going up underneath there, kind of finesse that on in there, getting a little bit of, getting a little bit of bump in there, and thinks he's in the right spot. He's going to pass the tracheal tube down over top of it, have an assistant. Now notice he is keeping the laryngoscope in the patient's mouth. And what does that do? That keeps the tongue up out of the way and keeps all the structures up out of the way. And it lets you confirm that the bougie hasn't fallen out of the trachea for some reason, which can happen. He's going to be able to pass the entire thing in there and then cuff up bougie out, leaves the tracheal tube in place, and puts it on end tidal CO2, which you have on every tube every time, to confirm that he is in the right spot. Very cool. Now, I mentioned before, if you get hung up, a lot of times what can happen is that as you've got the trachea, or as you've got the bougie going in, what'll happen is that it's sitting in the trachea itself, something like that. Yeah. When it gets down there, it will the bougie itself will be able to pass through, but the tube may hang up on the arytenoids there on the vocal cords. All you have to do in that case is give it a counterclockwise turn about 90 degrees and it'll slip through, because the bevel on the end of the tube will flip over and it'll jump into the trachea itself. And if you want a better view of that, I'll show you here in just one second. Here these guys do the same thing. Bougie goes in, and you'll notice that the tube is going to get hung up, gives it a little twist, 90 degrees, there it goes in. Rather than banging on the thing over and over and over again, just give it a little twist and the thing will go in place. Now, the idea of what happens if I'm by myself and I have to load this thing, how do I do that? Well, this is one way that you can do it. You'll notice on the GlideScope screen back there, here he is. All right, he's looking for a view. He's got a view, comes in with the bougie. But what he's going to do is transfer the bougie into the same hand that's holding the laryngoscope. And he's going to pin it there, and then he's going to slide the tube over the back of it there. Now, I can't say that I like that much, because you do lose control of the thing. It's probably going to be okay, but sort of like walking across the interstate, 9 out of 10 times, you'll probably be all right when you do that. The 10th time, when something bad happens, though, something's going to really bad happen in a really bad way. So that is one way you could theoretically do it if you were by yourself, although most of us probably shouldn't be by ourselves if we're intubating somebody. All right, that is how to use the bougie. And one of the big things that we'll hit on before and after is that you have to know how to use this thing and have to practice with it. It's not enough to just say, oh yeah, I heard about that in medic class, or I heard about that in CE or something like that. You have to practice using the thing, and you'll see why in just a minute. So, what's the evidence to say, like, yeah, we're using the Bougie First? Is there RCT to back that up? And it so happens that, yes, there is. This was from 2018. This was the BEAM trial. What these guys did, this was in an emergency department, in an academic emergency department, where the intubations were done by a third-year resident or an attending for the most part. So fairly high-level physician in an academic ED who were randomized to either doing a Bougie First, like going and getting your view, usually with video, but going and getting your view, and then you're either handed a bougie or you're handed a tube, and they knew which one they were doing ahead of time, but it was still randomized. You couldn't really blind it, but you do what you can. Anyway, so you either went in with the Bougie First, regardless of the predicted difficult airway or not, or the endotracheal tube first. So, and then they measured the first pass success for the most part, because again, that's the thing that you really want. Anybody could eventually probably get a tube, but you really want to know if it helps on the first time, especially in the setting of the primary thing they looked at, which was a difficult airway. So, if the patient had anything that would qualify it as a difficult airway, meaning again blood in the airway, obesity, they had a C collar on, anything like that, they vomited. If they had any of those difficult airway markers, then they looked at the first pass success rate, the chance that you got the tube in the trachea on the first attempt. And they found a 96% first pass success rate with the bougie and only 82% with an ET tube itself. 82%, you may still say, well, that's still not too bad. But when you really think about it, 1 out of 5 people is going to go on that rapidly increasing curve of complications, though, and that's probably more than we want. So anything we can do to make that less is good. So 96% is better than 82%, and that's statistically significant. They looked at it in all patients. So the chance that you got first pass success, whether or not you had a difficult airway marker on your intubation, was significantly higher with the Bougie. They looked at the time that it took to get in the trachea if you got success on the first time. So one thing to note, if you get the tracheal tube in on the first pass, then it is a little bit faster to use just the ET tube and the stylet. It's about 4 seconds faster, 34 versus 38 seconds. However, that's only if you get it on the first time. So yes, it's a little bit faster if you can get the tracheal tube in on the first time, but how does 4 seconds make a clinical difference? We can certainly debate about that. But if you didn't get it in on the first time, then it took, of course, significantly longer with the tube, because then you have to make another attempt at it. So again, 4-second difference, take that for whatever you want. If you get it on the first time every time, like, okay, maybe 4 seconds is a big deal. But if you're increasing the chance that you get it in, that's probably the bigger deal in my book. But that is what it says. And then they looked at some subgroups. What about folks that had cervical spine immobilization, blood in the airway, or obesity? All the stuff that we sort of think, yeah, this is going to be a difficult airway. That was all significantly higher as well when you use the Bougie. Of note, if you are immobilized, if you have a C-collar on where somebody's like holding that stupid manual inline stabilization that you don't actually have to do, or God forbid they are keeping the C-collar on when they're trying to intubate. Jesus. You had 100%, or they had 100% first pass success with the Bougie, and less than an 80% first pass success when they tried to use the ET tube itself. So this is probably something we should definitely be doing in all our trauma patients, in my opinion. But see my other talk on why the whole idea that we're holding manual inline stabilization and keeping people in seat collars during their intubation attempt is silly to start with. Nonetheless, better if you use the Bougie. So the takeaway from that, we should probably use the Bougie for our first pass attempt every time. Cool. That's the RCT. That should be relatively practice changing. It's a well done study. It's well powered, and it does what it says that it does. So, but is it always the best though? Is it always best to use the endotracheal tube? That is in one setting. It is a single study. Let's look at another study here, and this is a little bit older. This is 2011, if I recall, where they did kind of the same thing. They looked at Bougie use in an academic emergency department and your success after that as a result of as your first pass success. Now things are a little bit different here in that these guys had folks intubate who were all the way from interns up to attendings. So a wider swath of people, wider swath of airway experience, and these guys were not really that used to using the Bougie, so this was kind of a new thing for them. They had about a 72% first pass success rate with the Bougie. The most common reasons they cited for not being able to get the Bougie in or not being able to use it was they couldn't get it past the hypopharynx, which is probably a technique thing, and they couldn't pass the tube over the Bougie, which is also probably a technique thing, most likely. And of course, this is a new thing. I mean, their training on it was like you got a 5-minute didactic, and then I think you got to intubate 2 mannequins or something like that. One regular and then one difficult airway mannequin with the Bougie. So 5 minutes plus 2 mannequin scenarios. Not that extensive a training, where it is worth noting that in the BEAM trial, the thing we looked at before, those guys all said, yeah, we're pretty comfortable. We actually use the Bougie pretty frequently in the ER, so maybe this isn't that much of a trial of like introducing a new thing. This is just Bougie versus ET tube itself, but they had better success with the Bougie. Nonetheless, what I'm kind of getting at is that training makes a difference, in my opinion, I think is what this shows. You still get good first pass success with the Bougie itself, but it's not as good as if you train on the Bougie and you're comfortable using it. 5 minutes in Con Ed is probably not enough to say that, yes, I am ready to use this thing. But the real big problem with that, I think, is that we're still thinking of this thing as like the rescue device. People are still saying, yeah, I'm going to use the Bougie as my backup. Well, when's the last time you really used that? When did you actually intubate somebody with this last time? The thing that you are going to rely on to back you up, shouldn't that be the more experienced thing, the thing that you're definitely good at? I would say that most of us are not good enough with this to say this is going to be my backup device. Maybe an iGel? Yeah, okay, cool, something like that. A King Airway, something along those lines. But to say that the Bougie is going to be my backup, why don't you just use the Bougie first, and then you get your hands on it, and then you get used to using it, and then you can say, yes, I'm going to go ahead and do the tube, but then after I'm facile with it, now the Bougie is going to be my backup. So what I'm getting at, use the Bougie on lots of people. Use it on intubations where you don't think you're going to have a problem. Get your hands on it, get the thing out, invest $10 into opening one for your service, and get everybody out there on each shift day and say, all right, just put the thing in. Just practice with the thing. Try it that way. Try it with the Kiwi grip so that you can get used to doing that and see if that works a little better for you. Practice just straightening the thing out into the shape that you want. Get your hands on the thing so that you're used to it. It goes back to the old adage. Does anybody know what this is? You have like 3 seconds to answer that. Nobody actually knows the shape, but you've heard the adage. This is Carnegie Hall. How do you get to Carnegie Hall? You practice. And you got to practice with the Bougie the same way. So you can get to the Carnegie Hall of airway management, but it takes practice. And you got to practice with what you're going to use at the time. So, some key points real quick, and we will wrap this up. Number one, your first attempt has to be your best. So at the first time, the first thing you put in the patient's mouth, make that the best attempt, and that's probably going to be the Bougie when you practice with it. Start with the thing in your hand so that you don't have to drop something else and then pick up the best thing. Start with the best thing in your hand so that it's already there. And then practice with the thing that's going to be in your hand. You have to practice with the Bougie if you're going to use it. Don't think that as a result of this lecture that you can get out there and pick this thing up and just start using it on everybody. You should start using it on everybody, but don't think that this is going to be like adequate training for you to say, yeah, I'm ready to go with this thing. Practice, 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 and we will see you next time.